topic today is renal function tests. All right. And in discussing these tests, we'll be reviewing some functions of the kidney, and some of those functions we have already discussed. You remember some of those? Reabsorption of certain substances, right? Water, sodium, so on and so forth. So we'll be touching base, when we go along different topics. Now, kidney, as you all know, is composed of structural and functional units, which are called nephrons, right? And you have millions of those. So you can see many of them over here. All right. All these nephrons are present towards the peripheral part of the kidney, which is the cortex. The tubules will go deeper into the medulla, right? Now, all these nephrons, basically the blood will flow through these nephrons. It will get filtered. The filtrate will pass through the tubules, and then reabsorption and secretion will occur there. And ultimately, you will have formation of urine, which will be collected in the area over here, renal pelvis, and will then travel through the ureter into the urinary bladder. Okay, one more point to remember: blood flow or blood supply of the kidney is very high. The blood flow is very high. Okay. If you look closely at the nephron, so you have the arterial blood coming over here through the afferent arteriole. The afferent arteriole brings the blood into glomerulus, which is a tuft of capillaries where filtration will take place. Okay, and then the efferent arteriole will take this blood, back, and then this efferent arteriole will pass along the tubules. Okay, and then it will continue as venule, taking the blood back into the veins. So the blood supply of kidney is different from the usual blood supply that you see, where you have artery becomes smaller, it gives branches which are called arterioles. Then they give branches which are called capillaries. Capillaries join, form venules and veins. But here you have a special arrangement. Okay, because this area, glomerulus, acts as a filtration membrane. So when the blood is flowing through these capillaries over here, large amount of fluid is filtered across the Bowman's capsule, and it flows through the renal tubules. Okay, I think we all are familiar with this, so I won't spend much time on this. Okay, if you want to summarize the functions of kidney, first and foremost, formation of urine, so you can get rid of the waste products. Also helps in fluid and electrolyte balance, and we have done this, I think, in enough detail in the past few weeks. Regulation of acid-base balance as well, right, by secreting H+, by reabsorbing bicarbonate. A lot of buffer systems are present in kidney tubules. We have seen all that. Excretion of waste products of protein metabolism, urea. Okay. Excretion of drugs and toxins. One of the major routes by which our body can get rid of drugs and toxins is kidney. And also, it secretes a large number of hormones. And we have touched upon some of those. Renin, you remember? Anyone? Renin? Okay. There are many others. Erythropoietin is a hormone which is produced by kidney, and it goes to the bone marrow and stimulates formation of blood cells. Then you have vitamin D. Vitamin D, the last step of vitamin D activation occurs in the kidney. And also they produce some prostaglandins. So these are the major kidney functions. Now, if you look at nephron more closely, you will notice that after the glomerulus and the Bowman's capsule, the proximal tubule, okay, is followed by the loop of Henle. After loop of Henle, you have the distal tubule. The distal tubule actually passes very close to the glomerulus again. And when it comes in contact with the same glomerulus, this is where you have these special cells, the juxtaglomerular apparatus. Remember? I know you all know this, you just don't want to tell me. Juxtaglomerular apparatus. Okay? So, this is the glomerulus, the Bowman's capsule, right? The distal tubule, you see, it's just passing next to the afferent and the efferent arterioles, comes in close contact with these, and the cells in this area are specialized to produce certain enzymes and hormones. And which enzyme or hormone is produced by these cells? Come on, tell me now. Renin. Okay, renin. All right. What else you think could be the function of this arrangement, where the distal tubule of the same nephron is passing very close to the glomerulus? In addition to producing renin, what other function you think it could perform? This arrangement is also very important. Each nephron has its own regulatory mechanisms. So, if, for example, a lot of filtrate is reaching the distal tubule, it can affect the function of this particular nephron. So, each nephron has its own regulation, feedback mechanism. This juxtaglomerular apparatus, I already mentioned to you, releases renin and also erythropoietin in response to a drop in blood pressure. So, it will release renin and erythropoietin. Renin will go and stimulate angiotensinogen all the way to aldosterone, if you remember. Erythropoietin will stimulate bone marrow to make more blood cells. And this is what I was telling you on the, in the last slide. It also plays a key role in auto-regulation of GFR. Auto-regulation of GFR. Now, this is happening for each nephron individually. Now, if you look at this picture now, which I have taken from the textbook, let me just hide the lower half first. Okay. Look at stimulus A. What is stimulus A? There is a drop either in blood volume or a drop in blood pressure. This will release renin, which will increase the amount of angiotensin 1, which gets converted to angiotensin 2, which itself is a vasoconstrictor. So, it will constrict the blood vessels, leading to an increase in blood pressure. Okay? So, problem solved. The stimulus was decrease in blood volume or blood pressure. By inducing vasoconstriction, you have brought back the blood pressure, right? At the same time, it will act on adrenal gland, producing aldosterone, which causes sodium reabsorption. So, plasma sodium concentration will rise, plasma osmolality will rise, water will also come with the sodium, so you have increased blood volume. This is again a recap, we've already done it in ample detail. Second one is now, if, look at stimulus B, if there is an increase in plasma osmolality, which could occur in cases of dehydration where you have lost water from the body, osmolality has increased. This will be sensed by the osmoreceptors in the hypothalamus, sending signal to the posterior pituitary, which will release ADH or arginine vasopressin, AVP, which will then reabsorb water from the kidney, increase water in the ECF, plasma osmolality will drop. So, these two are the major mechanisms in the kidney which regulate the water and electrolyte balance and help in maintaining blood pressure and blood volume. Make sense? Okay. Now, imagine three different patterns of three imaginary substances. Let me hide these two first. So, this is on the left. Now, this is the blood vessel. Okay. So, the blood is coming. This is glomerulus. and this is Bowman's capsule and the tubules down here. Whatever flows in the tubules will be excreted in the urine. All right. Now imagine this substance A, it got filtered but not much. Very small amount was filtered. And then it was passing along the tubules in the capillaries, and it was actively secreted into the tubules. Okay? And now it is being excreted in the urine. And none of it is going back in the blood. So most of it is now excreted by the kidney. But remember, filtration was very minimal, very small amount was filtered, but large amount is actively secreted here and is going out in the urine. No amount of this substance is going back in blood. Let's look at substance B now. Okay? What is happening here? It was filtered, but when it was passing through the tubules, most of it was reabsorbed, and very small amount is appearing in the urine. Very small amount is appearing in the urine. Okay? Let's look at third possibility. This one. This substance was filtered at the Bowman's capsule. When it was passing through the tubules, all of it was reabsorbed. And it is now going back. So whatever amount came in the blood is going back in the blood. Nothing is filtered by the kidney. Nothing is removed from the body. Okay? Now can you give me an example? Can you think of an example of, say, substance C? Something that freely gets filtered but then completely reabsorbed and nothing appears in the urine. We're talking about healthy individual. Can you think of any substance? Glucose, right? Glucose is freely filtered but immediately reabsorbed. So normally we don't have any glucose appearing in the urine. Can you think of any example for substance B? Substance B? Sodium, right? Sodium gets filtered, most of it gets reabsorbed, very small amount is appearing in the urine, right? So sodium is one example here. Now give me an example of this, an example of substance A. This must be something which is very disliked by our body, right? We don't want it back, so everything has to go out. So most waste products, right? Mainly organic acids. And as we discussed when we were talking about acid-base balance, our body is producing a lot of acids. So every day kidney has to get rid of those acids. That's why the pH of urine is always acidic, right? So this is true for substance A, true for most organic acids, B, most electrolytes, sodium as an example, and C, glucose, amino acids, any nutrients that get filtered will be immediately reabsorbed. Let's look at the glomerular filtration. What is glomerular filtration? Amount of filtrate produced in the kidney each minute. Normally the value is about 125 milliliters per minute. This is the amount that is filtered at the Bowman's capsule. This is not the amount that appears as urine because most of it will be reabsorbed later. This is just the filtration. Okay. Now factors that alter filtration pressure will change GFR. Now what causes this filtration? Remember when we discussed about, I think in the very first lecture, the factors that control the movement of fluid across the blood vessels. This is blood vessel, right? In the glomerulus you have the capillary. Across the blood vessels, what controls the movement of fluid going out or coming in? Two factors. Hydrostatic pressure pushes the fluid out, and plasma proteins bring the fluid back. So basically here so how much filtration pressure is there will determine how much fluid goes out. Okay. So any factor that alter filtration pressure will change the GFR. Simple as that. All right. Now tell me any of the three patterns that I showed you in the previous slide, any of these three patterns, can you use any of these substances to calculate filtration rate? I'll show you the picture again. Look at this. Can any of these substances, substance A, B or C, can you use them to calculate filtration? When you want to measure filtration, you don't want any reabsorption or secretion occurring. Only then you can, so a substance which is only filtered not reabsorbed and not secreted, only that substance will give you an indication of kidney's filtration function. So none of these qualifies actually, right? You need a substance which gets filtered at the Bowman's capsule, and after that it just passes in the tubules. Nothing happens to it in the tubules. No reabsorption, no secretion. If you have that substance, you can use that to measure kidney's filtration rate. Do you know of any such substance that can be used to measure filtration rate in the kidney? You must have heard its name. Creatinine. Okay, creatinine. Creatinine is such substance. It's actually a byproduct of muscle metabolism, and its amount in the blood is quite constant. And this is a substance which is only filtered. So whatever you see in the urine has come out only through filtration. There has been no reabsorption, there has been no secretion. So you can use creatinine as an indicator of kidney's filtration function. Does it make sense? Okay. Okay. Now before we look at creatinine and creatinine clearance rate, just try to understand the concept of clearance. What is clearance basically? Simple definition of clearance is when blood flows through an organ which can remove substances from it, which has the ability to remove substances from it, the efficiency of that organ is reflected in clearance of the substance from the plasma. Okay, so how much this particular substance this organ can remove from the blood when it is passing through is basically clearance. All right. So if I go back now to the same picture, now you tell me which substance is cleared mostly. So which one, A, B or C, which one is cleared completely? A, right? A. When the blood entered kidney, this substance was present in the blood. When the blood is leaving kidney, it's no longer there. So kidney has completely cleared this substance out. Okay? Completely cleared the substance out of the blood. So here the clearance is 100%. So do not confuse the concept of clearance with glomerular filtration. All right? Now calculation of clearance is very, very simple. If you want to calculate the clearance, you look at the concentration of substance when the blood was flowing into the organ, and you look at when it is flowing out of the organ, right? So see the difference between the two. So basically it is calculated by using this formula. So clearance multiplied by the concentration of this substance in the plasma equals to the volume of urine and concentration of this particular substance in the urine. So you are comparing the two. Okay. If you rearrange the formula, it becomes like this. So clearance should be equal to U multiplied by V divided by P. So if you have the values of all these, and the values are not so difficult to calculate. So if you have the values, you need to measure urine volume, right? You need to measure the concentration of this substance in the urine and in the plasma. If you have these three values, you can calculate clearance very easily, right? Okay. Now clearance is used to measure GFR. It is used to measure renal blood flow, and it is used also to study renal handling of different substances. So clearance can be used, the concept of clearance can be used to measure all these different parameters. It depends on which substance you're looking at. So if you're looking at something, for example, creatinine, which is only filtered, not reabsorbed and not secreted, you will be measuring the GFR. If you're looking at something, okay, now renal plasma flow or renal blood flow, that substance which is completely reabsorbed by the kidney, so whatever amount will be present in the arterial blood coming to the kidney and the venous blood leaving the kidney will be the same. So this substance can be used to calculate the blood flow through the kidney. So depending upon what you want to calculate, you choose the substance you apply the concept of clearance and the formula of clearance, and you can calculate different renal function parameters. Most commonly we use this one, the GFR. Now let's look at these common laboratory tests which will tell you about kidney function. First of all, clearance of creatinine. So if you're calculating the clearance for creatinine, this will tell you about glomerular filtration rate. In order to measure GFR now, what will you need? Remember the formula for clearance? You will need concentration of creatinine in the plasma, concentration of creatinine in the urine, and the volume of urine. If you have all these three values, you put in the formula, you will have GFR. Okay? This is the standard lab method to determine glomerular filtration rate. But then there is a problem. It's not an easy laboratory investigation to do. You need the patient to be in the hospital or in the lab. You need to collect the urine sample, blood sample, measure all these, and then calculate the GFR. So, in order to overcome all these challenges, what we nowadays do, we do this eGFR, estimated GFR, rather than measuring creatinine everywhere in the blood, in the urine, and measuring the urine flow rate and all that. We use formula to predict GFR. So we only measure serum creatinine, and there are certain formulas which can calculate GFR for us. Okay, the two formulas that I'm going to discuss with you. First one is Cockcroft-Gault and the MDRD. I'll discuss these formulae later. Okay. There are few other substances which can be used for GFR, but urea can give you some assessment of clearance, but is no longer used because there are many factors that can modify, because it's not only filtered, it's also there is some reabsorption and excretion occurring. Cystatin C is also sometimes used. The levels remain stable if kidney function is normal, so it's useless if the kidney function is not normal. So creatinine is the gold standard which is used for calculation of GFR. Within subject variation is less, and between subject variation is also less, making it more helpful in monitoring an individual. So there is no diurnal variation or variation with the food, the diet the patient is taking. So creatinine is quite stable. That's why it can be used as a good indicator of renal glomerular filtration rate. Make sense? But now, as I was telling you, creatinine clearance has limited use due to inconvenient and difficult sampling, because you need to measure the urine flow rate. So you need to have multiple samples. So patient has to stay in the hospital or in the lab, so you have to take samples regularly. Okay. Sampling error could occur if patient is not producing enough urine, or there is anuria, severe dehydration. You can't collect urine, so you can't calculate GFR. So there are some limitations of this. So the solution is, as I was telling you earlier, you use certain formulae, okay, and you calculate GFR, eGFR, estimated GFR. Okay. Creatinine clearance and eGFR. So you can make use of the body surface area. As I told you earlier, creatinine is coming from the muscle. It's a byproduct of muscle metabolism. So depending upon the build-up of a person's body, the muscle mass, you can actually calculate how much creatinine will be produced by this person, and you can use different formulae. I'll show you some formulae later. So these formulas that we use, they take into account the age of the patient, the sex, ethnic origin, body weight, and these are two formulas which are commonly used to calculate creatinine clearance just from the serum creatinine level. Let me show you the formula first. This is the Cockcroft-Gault equation, or just CG equation, easier. So you need what? You need serum creatinine, right? Nothing else. All others are values. So you have age, weight, and you just put this with serum creatinine, and you will get estimated GFR. In case of females, you multiply the value with 0.85. Okay, and if the person is overweight or obese, rather than using the actual weight of the patient, you use the ideal body weight, IBW, for that particular height of the patient. As you know that the different charts are available, you see what is the ideal body weight for that particular patient, and you put that. Okay, so that you can have an eGFR. Of course, it is not the accurate measurement of GFR, but it is the nearest we can get by just taking one serum creatinine sample. You can have eGFR. Okay. The second formula, which is MDRD, is little more complicated than the previous one. Again, the only thing you need from the patient, the measurement, is serum creatinine. That's all. The rest you just put these values, age and everything, okay, and you multiply by 0.742 if the patient is a female. It is expressed in milliliter per minute per 1.73 meters square. Another formula which can be used here. Now, this formula was developed in the US, and they found out that it can also, between ethnic groups, you can pick up differences. So, for African Americans, the result, you have to multiply it by 1.212. So, you can even pick up differences between different ethnic groups, which CG formula cannot. So, if you look at the comparison of these two formulae, this was developed earlier in mid-1970s. This one is developed much later. This one takes into account age, sex and weight. This one takes into account age, sex and the ethnicity of the patient. It doesn't take into account the weight. That's why you look at the formula that expresses the GFR 1.73 per 1.73 meters square, because it didn't take into account the weight of the patient. All right. This one is widely used to calculate drug dosages, and this one is more commonly used in biochemistry reports. So, most of the clinical biochemistry labs, when they measure serum creatinine level and they report the estimated GFR, most commonly they use the MDRD formula. Okay. So, this is just the population where these formulae were developed. So, looking at the sample population, they generally had a low GFR, and when this was developed, the population generally had a higher GFR. So, this is just the confounding factors you have to keep in mind, because these formulae are giving you an estimate. They cannot be an actual representation, 100% representation of patient's condition. The most important thing about these formulae and creatinine clearance is that we are not actually worried about one value from the patient. We are actually monitoring the patient. Even though it is not an accurate value, but if you are using the same formula, same technique, and measuring the eGFR in the same patient over a period of time, you can see the trend, whether GFR is increasing or decreasing. So, it's more important in following up the patient. Okay. Now, this eGFR is automatically generated by most labs, and when you will have the lab report in your hand, eGFR is already there. So, they have used the formula, they have calculated it. Serum creatinine level will be given together. It is accurate if used appropriately. So, the CG equation is more accurate if the patient's GFR is low. So, both of them, they have their pros and cons. Just some of them are listed here. Less accurate in higher GFR, and no specific result if it's more than 60 milliliter per minute or 1.73 meters square. So, it becomes invalid if the GFR is too high. Less accurate in patients with abnormal body shape or mass amputees. For example, somebody had both lower limbs amputated. You're using a formula. A formula will not take into account the amputation. A lot of muscle mass is gone in this patient, right? So, the formula may not be an accurate representation of GFR, or there is too much muscle wasting. If there is too much muscle wasting, you should use the CG formula, because CG formula takes into account body weight. The MDRD does not take into account the body weight. So, in case of muscle wasting, it's better to use the CG formula, right? MDRD is affected by consumption of meat. So, if somebody is eating a lot of meat, can also affect the calculation of EGFR. So just keep these limitations in your mind, that EGFR is basically an estimated GFR using this different formula to calculate the GFR. So the only value that you need from the patient, the only laboratory value is serum creatinine level. That's it. All the others you put in the formula, you get the result. Okay. Now what GFR tells you, these are GFR values. The normal is 125, right? 125. So if you have more than 90, this is okay, this is normal. So CKD means chronic kidney disease. So if you're looking at a patient with chronic kidney disease, if GFR is above 90, so there may be some kidney damage because it's a chronic condition, but with normal or even increased GFR. And this is labeled as stage 1. Stage 1, chronic kidney disease. Stage 2, when the GFR falls between this range, 60 to 89. If it goes down to this level, 45 to 59, we call it stage 3A with moderately decreased GFR. So stage 3B, stage 4 and stage 5. Stage 5 is kidney failure. Usually stage 4 and stage 5 is the level where you will definitely require either dialysis or kidney transplant. Because this, if the GFR is this low, kidney will not be able to get rid of the waste products and the patient will accumulate urea and other waste products in his blood. Okay. There are a few other parameters which are used to assess kidney function in addition to GFR. Urea is an end product of protein metabolism, and we have discussed this thing before, right? It is an osmolar substance. It can affect osmolality of the plasma. Sometimes when you have this increased osmolar gap, can be due to presence of urea, if you remember. Okay, an iron gap, stuff like that. It is mainly excreted by renal excretion. Small amounts are also lost through skin and GIT. Urea is not so useful. So basically we calculate what is known as blood urea nitrogen, again using a formula, because we know that one urea molecule contains 2 molecules of nitrogen. And we just know that this is the relationship of urea to blood urea nitrogen when we do the conversion. So usually the report that you will give or you will see, it will be written as BUN, but they have measured urea, but they calculate BUN and report as blood urea nitrogen or BUN. Okay. Previously used as an indicator of kidney function, but this has poor sensitivity and a lot of interferences are there. So nowadays it is not regarded as a very good marker of kidney function. Okay. Still useful if you use it together with GFR. So GFR and BUN, if you look at them together, BUN can give you an idea about kidney function, but standalone BUN is not a good marker of kidney function. Just remember that. Okay. GFR is much more important to look at. Beta 2 microglobulin, this is used to assess renal tubular function. The difference between this and the previous one, in GFR we are looking at filtration when you are measuring creatinine. Here when you are measuring beta 2 microglobulin, you are actually assessing the tubular function. When you say tubular function, what is tubular function? Mainly reabsorption, but also some secretion. So basically you are assessing the ability of kidneys to reabsorb substances when it is passing through the tubules. It is usually used in patients with renal transplant. Okay, and if it is elevated, it indicates that the kidney is being rejected. So it's a bad sign if it increases in a patient who has received renal transplant. So it's a very good indicator to see whether transplant is accepted by the patient or not. Blood and urine beta 2 microglobulin test can be ordered to evaluate kidney damage and to distinguish between disorders that affect glomeruli and the renal tubule. So you can actually compare the amount of beta 2 microglobulin in the blood and in the urine. So it can give you a good indicator of the tubular function of the kidney. Myoglobin is a type of protein which is present in the muscles, similar to hemoglobin, but it is in the muscles. It actually binds to oxygen. blood levels of myoglobin can rise very quickly with severe muscle injury. When muscle injury occurred, the cells are damaged, myoglobin can be released into the blood. Okay, and also in rhabdomyolysis, severe muscle injury. So myoglobin can give you an indicator, and this myoglobin can actually cause acute, if there is too much myoglobin, it can damage the kidney. Okay. Now, another test which is commonly used is called microalbuminuria. Now it is called albuminuria. The micro has been taken away. So albuminuria. Presence of albumin in the urine. Okay. It is very important in the management of patients with diabetes mellitus who are at risk of nephropathy. If you remember, diabetes mellitus is a chronic disease and it has a lot of complications. You have problems in the eyes, problems in the kidney, problems with the blood vessels, right? So kidney damage, if it is occurring due to diabetes, the first thing that appears in the kidney is albuminuria. So it could give you an indication that diabetes is affecting the kidney. So it's an early indication of diabetic nephropathy. Okay, diabetic nephropathy. In later phase of nephropathy, when the kidneys are damaged at advanced level, increased glomerular capillary permeability allows the amount of albumin, then the albumin will be appearing in very large amounts. So microalbuminuria or albuminuria is an indicator of early damage, but when damage is advanced, you will have large amounts of albumin coming in the urine. So for this albuminuria, you have to collect 24-hour urine. Okay, and if you find there is more than 30 milligram of albumin, it is diagnostic of albuminuria. It means that there is damage occurring to the glomeruli and they are leaking the protein albumin into the urine. Okay. One more test which is not very commonly used, but it can be used. Again, it's a protein which is expressed by neutrophils and epithelial cells, also the epithelial cells of the proximal tubule in the kidney. In cases of acute kidney injury, acute insult to the kidney, you can have elevated levels of NGAL within 2 to 6 hours. So this is sometimes used as a very sensitive indicator of acute kidney injury. Not in usual practice, but in special cases you can look at this. Okay. Now we come to the last topic, urinalysis under the analytical procedures. Now urinalysis permits a detailed in-depth assessment of renal status with an easily obtained specimen, because you don't have to take any specimen, put patient in pain or something. So urine is the easiest sample to collect, and it serves as a quick indicator of glucose status and also the liver and hepatobiliary function. Can anyone tell me how it can tell us about hepatobiliary function, the urine? Okay, let me ask you another question. Why do you think urine is yellow? Bilirubin, not bilirubin, but urobilinogen. Bilirubin gets converted into urobilinogen. So, and this is produced by the liver. So, if there is jaundice, if there is too much bilirubin, the urine will become deep yellow, right? So, it can give you an idea about the function of the hepatobiliary system. All right. Routine urinalysis will include 3 components: physical examination of the urine, chemical analysis, and then microscopic analysis. You look at the urine sample under the microscope. So physical characteristics like color, smell, clarity, is it turbid or clear? Chemical analysis, we will look at it later. Microscopic examination, what do you think? What are you looking for? If you're looking at a urine drop under the microscope, what do you think you're looking for? You can't see glucose molecules, right? You can't see sodium there. So what are you looking for under the microscope? Any idea? What are you looking for under the microscope? Cells, yeah, cells. So you're looking for cells. If there is, for example, infection, you may find white blood cells, neutrophils. If there is damage to the kidney, you may find red blood cells. Okay. There are sometimes crystals and casts present in the urine, so you can look at those as well, or parasites in rare cases. Okay. Now urinalysis, before we look at that, you want to have like a 5 minutes break? Okay, then we'll start. Okay.